So just to make it clear, the first part of my talk was the general hemodynamic management. I'm now going to talk to you about our special pharmacological intervention. And obviously Mervyn was really skeptical. Well, he wasn't really alone, because my colleagues, when I told them what was going on, thought it was the biggest lot of nonsense they had ever seen. But then they actually saw that none of our patients were dying, and then our CEO saw that none of the patients were dying. So this has become actually instituted throughout our whole healthcare system. And we were going to do an RCT, but we couldn't because it would have been unethical. So that's just the starting point, and I already hear, but it is what it is. So it's a story. So I think, like most stories, it's worthwhile telling some other stories. Always a story within a story. So we need to talk about Ignaz Semmelweis. He was an obstetric resident in Vienna in the 1800s. And what was quite interesting at that time is that in the Vienna, lying in hospital, there were two wards. The ward, which is illustrated in green, was run by midwives. The ward in red was run by obstetricians and academic physicians. And the risk of dying, as you can see from purple, sepsis, was significantly higher in the first lying-in ward than the second lying-in ward. And they had this randomization scheme, which John would like. It was like every other day you were randomized to one other unit. And he was intrigued by this difference. He couldn't understand it. And then he made the observation that would happen in the morning is the obstetricians would go, they would do autopsies, and then they would go from the autopsy room and do vaginal examination deliveries without ever washing their hands. So he surmised that they were transmitting something. So he instituted hand washing with chlorinated lime. And he noted this dramatic reduction in mortality. So he presented this data, and he was ridiculed. He was laughed at. He was mocked. How could it be possible that washing your hands could prevent these women dying of puerperal sepsis? It just didn't fit with the pathophysiology of the day. He was ridiculed, and in fact, he was kicked out of his program, and he lost his job. It even went worse. He tried to present this at medical meetings and was booed and was hissed, and was in fact declared mentally insane. He was admitted to a mental asylum involuntarily, and actually died 2 weeks later trying to escape. So my story is almost identical. We have a before and after. So my advantage is that I outlived Ignaz Semmelweis. He died at 47. Secondly, as Rob knows, I'm already been declared mentally ill, and receiving therapy, so that's not going to work. But my advantage over Ignaz is I have an enormous base of solid scientific data to support me, whereas unfortunately he didn't have that because people didn't know about bugs like Mervyn was talking about. He talked about cadaveric particles. So my story is exactly the same, and presumably most of you are going to be as skeptical as the audience was when Ignaz presented his data, but that's fine because you know what, we'll see the truth. So sepsis is a global problem. About 20 million cases per year. The mortality in resource-poor countries is about 60%. So this is a really important disease, and a lot of people die. We know that all the pillars of surviving sepsis have come crashing down. There's not a single element in surviving sepsis that actually has any scientific basis at all. We also know that there have been over 100 phase 2 and phase 3 clinical trials for sepsis. And we know that we had activated protein C for a transitory time, but basically there hasn't been a single molecule or intervention which has been shown, until today, to change the natural history of sepsis. This is from Professor Edward Abraham. Sepsis is a common, life-threatening, and increasingly frequent medical problem that consumes huge amounts of resources. Mortality remains high. The long-term effects, including total disability, severe. We desperately need new diagnostic and therapeutic approaches to sepsis. hopefully I will share some of those with you today. So I'm going to talk about our magic bullet. John doesn't believe in magic bullets, but you make your own conclusion for sepsis. So this is drug A and drug B, and it wasn't that we decided one day we were going to find the cure for sepsis. Like most things, the apple falling out of the tree, it just happened. It was a fortuitous set of circumstances that led to us doing what we did. So we give drug A and drug B. It's very mysterious. They're both anti-inflammatory, increase pressure sensitivity, preserve endothelial integrity, ready available, cheap and safe. Both drugs have been available since 1949. Interesting, both were released in 1949, tested for the same disease. So we have hundreds of scientific articles going back to 1949. So this is not something new that I've invented. It's been there. It just took us to, we think, put the pieces together. Drug A and drug B. So now I'll take you out of your misery. Corticosteroids and vitamin C. What? You've got to be kidding. Okay, so what I will do is I will show you our data, but more importantly, I'll show you the underlying scientific data and rationale of why this is just so cool. It's really cool. So I wrote a little editorial, vitamin C and vitamin C for the treatment of severe sepsis and septic shock. This is our little recipe. Vitamin C, hydrocortisone 50 Q6 for 6 days. And then taper, we've kind of changed that a bit. Vitamin C, 1.5 grams Q8 for 4 days. And for good measure, we threw in thiamine, but you'll see the rationale for the thiamine. So this is our study. It's a before-after study. We collected enough data to make it semi-robust so I could present at this meeting. And also we felt that we had an ethical imperative to spread this data because I think this saves lives. And I think that there may be skeptics in the room, but as I'll show you, it is completely safe. You have nothing to lose except a surviving patient. So this is our study. It's published in Chest as an EPUB. It's available now. I'm not going to go through all the data. I think what's much more important is the scientific underpinning of the study, which is profoundly strong. So basically, this started just by accident on the 5th of January 2016. We had a patient dying of overwhelming sepsis. This lady was 48 years old. She had E. coli and Clostridia perfringens in the blood. She was going to die in front of my eyes. And we thought, you know what? Let's try something. And this was the something we did. The next day, she was extubated off presses. And we said, shit, what just happened? So that's really how it started. So we collected patients over 7 months. We used the same inclusion and exclusion criteria. We used procalcitonin level than greater than 2. We didn't really know what we were doing then, but you'll see how important the procalcitonin is. We had a control group treated exactly the same. So I outlined to you our protocol. And that we've been doing for 2 or 3 years. So nothing changed. Nothing changed between this time except the period of the sun and the moon. The only exclusion criteria were if you're less than 18, if you were pregnant, or if patients had a limitation of care on admission to the hospital. As I said, this is our management strategy, which we kind of went through. Our outcome measures were hospital survival. That's kind of an important outcome that most patients would really be interested in, as well as some other things which provide really physiological, really remarkable justification for what happened. So the patient characteristics I'll go through quickly, really typical of patients in the U.S., about 60 years old, half were getting presses, lactate about 3, had a really high procalcitonin. So we measured vitamin C, not in all patients because it requires special testing. So I point this out because it's quite important. The normal blood levels, as we'll see, is 40 to 60 micromoles. You can see the average level was 14. These patients, there were some patients who had undetectable vitamin C in the blood. As I will tell you, critical illness is an ascorbitic disease. It does not differ from scurvy. These patients have acute scurvy. If you're critically ill, your vitamin C levels are profoundly reduced, if not undetectable. And you can see the levels were really low. The patients had severe comorbidities. Unlike some of the other studies, apart from 2 patients, they all had severe multiple comorbidities, which is typical of our patients. And you can see about 20% of them had severe morbid obesity. It's a pandemic where I come from. The diagnoses were pretty similar: pneumonia, urosepsis, primary bacteremia, GI. The day 1 SOFA, much like what we've seen today, the day 1 SOFA was about 8 and 8.7, had a very high Apache 4 score. We collected Apache 4 scores, and that allowed us to assess predicted mortality. So you can see this was a sick group of patients with a predicted mortality of 40%, much like the data Mervyn showed, showing that patients with severe sepsis and septic shock have a mortality of about 40%. As I said, we use a fluid restrictive strategy. We closely monitored fluid balance. You can see fluid balance at 24 hours, 2 liters, at 48 hours, 1.9 liters. So this compares to the 13 liters of fluid that is given in early goal-directed therapy. So these patients were truly, we gave them fluid, but we had a fluid restrictive strategy. The outcome, which people say, that's BS. It's just too good to be true, John's going to say. Can't be true. But you know what? I have no reason not to present the truth. So this is the truth. You can see in the control group, the mortality was almost as predicted, 40%. The mortality in the treatment group was 8%, which was 3 patients. Those 3 patients left the ICU alive, off presses, off a ventilator. They had severe end-stage Alzheimer's, severe sarcoidosis, and severe cardiomyopathy, which we didn't know at the beginning. Those patients had their treatment withdrawn. They did not die of sepsis or sepsis-induced organ failure. So we thought that was cool, but you know, the editors want us, I think data should speak for itself, but no, they wanted us to do statistics for dummies. So you get this book and you do statistics for dummies. So we did logistic multivariate analysis to get the whole group. And you can see that variable, which was most highly predictive of mortality, was our treatment intervention, followed by the Apache 4 score. They then wanted us to do propensity matching. So we said, no, we're going to do propensity adjustment. So every patient got a propensity to get vitamin C, and then the endpoint was adjusted by that propensity. And you can see the odds ratio was 0.13, which people say is ridiculous. You know, it is what it is. I can't help it. It is what it is. So the outcome, as you can see, the hospital mortality 9% versus 40%. Duration of vasopressors, and this is the most fascinating part of the study because this is real. And Tony presented the data on norepinephrine. If you had a look, patients were on norepinephrine for an average of 50 hours. The mean duration of presses in the control group was 50 hours. In the treatment group was 18 hours. It's really quite remarkable. Never been reported in the literature that vasopressor-dependent patients with sepsis get off vasopressors so quickly. And in fact, I'll show you a graph. It's absolutely predictable the time where vasopressors the dose becomes down titrated is 2 hours. You can march it off exactly on the flow chart. 2 hours after the dose of vitamin C, the dose of norepinephrine is down titrated. You can look at the procalcitonin clearance. Remarkably, our nephrologists are really mad with us because the need for acute renal replacement therapy has disappeared. They are being put out of business. The length of stay was the same because dying people take longer to die. So this is the time to discontinuation of all presses, and this on the y-axis is the norepinephrine equivalence. So you can see they were on a pretty hefty dose. Within 2 hours of their first dose of vitamin C, you can see the down titration of their pressor dose. The mean duration was 18 hours. No patient was on presses for more than 24 hours. Clearly, we never had a patient who died of refractory septic shock. This is the control group. So in green are the control patients who died. So you can see what happened. They had escalating doses of presses, and they died in refractory shock. Those who survived obviously had lesser severity of shock. You can see their doses went up and then came down, again, about 48 hours, compared to the patients who got the combination. So it was highly predictive. So in our ICU now, it's commonplace that we start presses early, which is part of this algorithm. We give them less fluids, and with this therapeutic intervention, they are off presses within 24 hours. So you want to look at the SOFA score. There wasn't a single patient whose SOFA score went up. So the SOFA score on those who died obviously is in the top. Red, the control group who survived, and remarkably, the SOFA score in the treatment group came down predictably. There was not a single patient who had an increasing SOFA score. Serum creatinine, this is in the treatment group. We couldn't do it in the control group because at least half were getting dialysis. So you can see that, excluding the 2 or 3 patients who had chronic renal failure, the creatinine came down abruptly. This was kind of important because you'll see one of the side effects of vitamin C that people are worried about is oxaluria and deposition of oxalate in the kidney. But you'll see how we overcome that, and we were pretty certain that this was helping rather than hurting. Serum lactate came down briskly. So this is a semi-log scale, which looks at the procalcitonin. And this was the most fascinating observation, is that the trajectory of the fall in procalcitonin was absolutely predictable. It switched off production of procalcitonin, and procalcitonin fell exponentially, so that it was half the next day and half the next day and half the next day. And what was phenomenal is that if it didn't follow this trajectory by 24 hours, we knew wrong antibiotic or inadequate source control within 24 hours based on the procalcitonin trajectory. You can see in the control group it just went up. And so we looked at procalcitonin clearance, which kind of speaks for itself. So I need to give you some background because this sounds too good to be true. And the background is quite fascinating. So first of all, this is the package insert, because people said you can't do this. This is not acceptable. So this is the package insert. It says there are no contraindications or side effects. You find any drug that you administer that has no contraindications and no side effects. It's indicated in patients with acute deficiency, which our patients had. Every single patient had an acute deficiency, and the recommended dose was up to 6 grams a day. So we actually complied with every single indication in the package insert of vitamin C. So just so you know, that's ascorbic acid. It's a simple little molecule. You can make it in your garage. It's a single electron donor and forms the ascorbate radical. Unlike other kind of radicals, it's actually not a bad radical. It can only react with itself rather than other radicals, and then can undergo dismutation to dehydroascorbic acid, or it goes back to ascorbic acid. It's a powerful antioxidant. Dehydroascorbic acid gets converted into that funny molecule and to oxalate. So that's where the oxalate piece comes in. But we have a nifty way of dealing with that. So one of the potential byproducts is oxalate. So what you may or may not know is that there are only 2 species on this planet that don't make vitamin C. For some evolutionary reason, primates lost the ability to make vitamin C. The only species apart from guinea pigs. So you can see that humans lost the final enzyme in this pathway to make vitamin C. So Linus Pauling knew this, and he found out that a little billy goat, he makes about 13 grams a day. When this little goat gets upset with the mommy goat or the daddy goat, it doubles vitamin C production. Vitamin C is a stress hormone. It is a stress hormone. The human adrenal gland secretes vitamin C. And you can see makes about 13 grams a day. So this is where he got the idea of he died taking 17 grams of vitamin C a day. But he kind of didn't know one really important thing. So, ascorbic acid. It's an essential vitamin for humans who lack the terminal final enzyme in the biosynthetic pathway. It acts as an antioxidant and a coenzyme. So people don't recognize it's a coenzyme for multiple biological reactions. It's absorbed by the gut by a sodium-dependent transporter, SVCT1. Linus Pauling did not know about this transporter. It is a saturatable transporter that gets saturated about 500 milligrams orally. So taking more than that, it's not absorbed. It circulates in the plasma about 30 to 50 micromoles. It then gets transported into the cell by SVC2, reaching much millimolar concentrations. So it gets concentrated in the cell 100-fold. I don't know any drug or pharmacological agent that actually gets concentrated in the cell 100-fold. So this is really important because we see here SVC2 is being absorbed, gets into the bloodstream, and then gets concentrated 100-fold. One of their glands is the adrenal gland. If you knock out SVC2 such that your adrenal gland doesn't absorb vitamin C, you switch off catecholamine production. You switch off catecholamine production. You switch off cortisol production. The adrenal gland needs vitamin C to make stress hormones. It then gets concentrated 100-fold in the neuron, which is really important because we know historically patients with scurvy went completely bonkers. And you'll see the relevance to our study. So this is really important physiology, and the molecular structures of these transporters has been clearly delineated. Again, the SVCT1, SVC2 into the cell, and particularly in certain organs gets concentrated. So it's a powerful antioxidant against superoxide and peroxide nitrate. Most importantly, though, it recycles other antioxidants. None of the oxidants do this, so it recycles vitamin E. Most importantly for us, there's an antioxidant called tetrahydrobiopterin, which is absolutely essential for nitric oxide synthase activity. If you have decreased tetrahydrobiopterin, you uncouple nitric oxide synthase, and instead of making nitric oxide, it makes superoxide. Very important. Vitamin C deficiency, therefore, has a profound effect on microcapillary flow. Again, it is absolutely vital that it maintains iron and copper-containing enzymes in the reduced form. And as you'll see, there are multiple enzymes involved in multiple biological reactions that require iron and copper-containing enzymes. If they become oxidized, the enzyme simply does not work. So you can see it's required for mono and dioxygenase, which is required for the synthesis of cortisol, catecholamines, and neurotransmitters. What is most fascinating, it's the only molecule that actually binds the adrenergic receptor and the beta receptor. It's the only molecule that binds to these adrenergic receptors and increases adrenergic transmission directly. It also has epigenetic effects. So this is one of the studies looking at the bioavailability, showing that as you give increasing doses of oral vitamin C, you get a flat level because of these saturatable transporters in the gut. So, ascorbic acid. All animals, as we said, except primates and guinea pigs, increase vitamin C synthesis during stress. Vitamin C levels are typically low in critically ill patients, and there are multiple studies showing that greater the severity of illness, the higher the Apache score, the higher the SOFA score, the lower the vitamin C level. And the low levels are due to enhanced metabolic turnover, as well as increased urinary loss. What is quite fascinating is you'll see pro-inflammatory cytokines decrease expression of SVCT1, so you get increased loss in the kidney. And you cannot get adequate supplementation orally. Your inflammatory cytokines decrease expression of both transporters. So IL-6, IL-1, TNF decrease expression of vitamin C transporters, so it cannot get into the cell. So mechanistic pathways in sepsis, it's a potent antioxidant preventing activation of NF-kappa B. This has been demonstrated in multiple studies. It preserves endothelial tight junctions, shown in multiple studies. It preserves the microcirculation, shown in multiple studies. It enhances T cell function. It enhances macrophage activity. Vitamin C is a cofactor for the synthesis of norepinephrine. As I said, if you knock out the SVC2 transporter in the adrenal gland does not make catecholamines. It's required for the synthesis of vasopressin in your brain. The highest levels of vitamin C actually are in the hypothalamus and the pituitary, required for vasopressin synthesis. If you are vitamin C deficient, your synthesis of vasopressin goes down significantly. It's a cofactor for the synthesis of dopamine. It's a coenzyme for the synthesis of cortisol. It's a cofactor for the synthesis of collagen. It binds to the alpha-adrenergic receptor, increasing activity. It binds the beta receptor, increasing activation. So you can see it's quite phenomenal that vitamin C, the simple little tiny molecule, acts via multiple pathways. So anti-TNF acts by one pathway, protein C by one pathway. This molecule acts by multiple pathways to interfere with multiple pathological processes in patients with sepsis. So there's a validated mechanistic basis. It's supported by basic science and supported by clinical studies. So the thiamine is really interesting because studies have shown that septic patients are thiamine deficient. And if you just give thiamine to patients with sepsis, you will reduce mortality. This is a study by Mike Danino at Mass Gen. They showed if you give septic patients thiamine, decreases mortality. But it's actually more interesting because thiamine is a cofactor, as you see, thiamine pyrophosphate is a cofactor for glyoxylate metabolism. If you're thiamine deficient, you increase production of oxalate. So the other reason to give thiamine is to prevent increased oxalate production. So what about the synergy between steroids and vitamin C? This is kind of like a marriage made in heaven. It's quite remarkable. So what happens with sepsis is you get oxidation of the glucocorticoid receptor. So we know one of the problems why steroids do not work. Why steroids do not work in sepsis, and probably why the adrenal study will fail, is that the thiol groups in the glucocorticoid receptor get oxidized. When the glucocorticoid receptor gets oxidized, cortisol cannot bind to the receptor, and it cannot bind to the DNA elements. So it interferes with glucocorticoid receptor function. Voila. If you give vitamin C, you restore glucocorticoid receptor function. Cool. It works the other way. Dexamethasone induces the transport protein, SVC2, to get vitamin C in the cell. We said what happens with sepsis, you get downregulation of the transporter. Sepsis upregulates the receptor. So, you may not believe anything I said before, but what I'll do now is show you in vitro data. So you may not, if you're skeptic, I'll show you in vitro data. So we said, this is the coolest thing. Let's take this to the lab. It just so happened that Dr. Kataris at Old Dominion University has a model which suited what we were doing perfectly. So he did this independently of our shenanigans. So basically he took human vascular lung endothelial cells. He has this method, this is a validated model, reported multiple times in the literature. He used transendothelial electrical resistance as a guide to endothelial permeability and viability. He then exposed this monolayer to endotoxin, and then as you'll see, we exposed it to ascorbic acid, hydrocortisone, and the combination. So this is what happens. Pardon? Just let you finish. Yeah. So you can see this is the transepithelial resistance at control group. This is what happens with endotoxin. If you give ascorbic acid, it does the same thing. You interfere with transepithelial resistance, the cell dies. If you give arachidonic acid, the cell dies. If you give hydrocortisone, the cell dies. You give the combination of hydrocortisone and arachidonic acid, you get this little dip, and it restores endothelial function. What we then did is we measured with Western blot, we measured protein expression. So you can see phosphorylated covalent is an essential protein required for tight junction formation. You can see what happens. LPS switches it off. It comes back again with arachidonic acid and hydrocortisone. The same thing with Rho A. Rho A inhibits tight junction formation. P53 expression is an anti-inflammatory protein. So the exact what you would expect happen. This is looking at barrier function, showing covalent, RAC A, and Rho A, the effect on endothelial function. So this is my last slide. So this was a study, a randomized control study. I think it was done in Britain, so you should be happy. They looked at patients' mood. These were hospitalized patients. If you're hospitalized, your vitamin C level is low. They did a randomized control trial comparing vitamin C to vitamin D. They looked at their mood and happiness index and found that if patients got vitamin C, they were happier and their mood was better. So, the magic bullet for sepsis, hydrocortisone and vitamin C, they leave the ICU alive and they leave very happy. What more could you want?